Hi there, my name is Dr. Wes Clayton, and welcome to the Foot Review on SportMedSchool.com. This lecture is meant as a review primarily, and is not completely exhaustive of all the number of conditions that can occur in sport and exercise medicine when it comes to the foot. However, hopefully it serves as a good review when it comes to studying for sport med exams, or as a review if you need to go back to it later on to refresh your memory of certain conditions or the differential when you see a patient presenting to your office or clinic. I've arranged the talk into three main categories: hindfoot, midfoot, and forefoot. And then on the differential page, in bold are the conditions that will be contained within this review, and certainly others as well can be looked up if needed and if you feel is appropriate. Mainly this lecture is designed as a review, so probably the best way to be using it would be to go through the lecture, pause, go back and forth to different slides as required. I'll try to, in speaking, highlight a few key principles of each condition that I feel are important, but certainly in your review, certainly use this lecture as you feel would be most beneficial to your studying. So let's start with the hindfoot. Before we get there, I have no conflicts of interest to disclose. So, calcaneus fracture. Certainly the most common tarsal fracture, and really grouped extra-articular or intra-articular. And with respect to the management of non-displaced injuries, varying degrees of immobilization are required. However, with displaced fractures, non-unions, or intra-articular fractures of the calcaneal body, really you should be involving your orthopedic surgeon. Especially when it comes to sports and exercise medicine, oftentimes we see extra-articular fractures, especially if they've been missed in follow-up in the office or when referred. So in particular, anterior process fractures tend to be misdiagnosed or missed when it comes to inversion injuries of the ankle, or certainly overlooked potentially as well. And so your patient presenting with persistent lateral hindfoot pain after an injury such as this certainly has to be part of your differential as well. In reviewing the various calcaneal fractures, you'll see just different mechanisms of injury there. In particular, when we're looking at not missing, in particular, a body fracture or inter-articular fracture, we look at two angles in particular, Bowler's angle and the crucial angle as well. And we can move to the next slide to review that here. Bowler's angle really is formed by a line drawn from the superior aspect of the anterior process of the calcaneus and the superior aspect of the posterior facet, and a second line that joins the posterior facet and the superior part of the calcaneal tuberosity. This angle should be 20 to 40 degrees, and if reduced, should alert you to the possibility of a interarticular fracture. The crucial angle, or the critical angle, is another line drawn from the posterior calcaneal articular surface and a second line drawn from the sinus tarsi and to the anterior process of the calcaneus. This angle would also be increased if a fracture is present. And the normal angle is 130 to 145 degrees. Really, when it comes to calcaneal fractures in general as well, one can't forget to consider other associated injuries, either in the other limb or other lower limb, and the lumbar spine in particular as well, or other long bone injuries, given the traumatic nature of a lot of these fractures. Ultimately, CT scan will be helpful in identifying subtle or inconclusive injuries in this area. Moving on to calcaneal stress fractures now. Again, typically in a couple different areas of the calcaneus, especially high impact activities and athletes involved in such. And you can see some predisposing factors here as a heavy landing, poor heel conditioning, and certainly screening for REDS would be appropriate in these patients if clinically warranted. An X-ray may demonstrate the injury, though a bone scan or MRI would be more definitive, and varying degrees of relative non-weight bearing or reduction in weight bearing activity over a number of weeks are likely all that is needed in this case. Sometimes a short period of immobilization if required, and certainly a REDS assessment is needed in these individuals potentially. Moving to a midtarsal joint sprain, we're talking on the lateral part of the hindfoot as well, involving the calcaneocuboid ligament or the bifurcate ligament, which is the lateral calcaneal navicular and the anterior calcaneocuboid ligament. Really what we're talking about is mostly inversion or violent dorsal or plantar flexion injuries, and most commonly in gymnastics, jumping athletes, soccer players, etc. We're looking at lateral midfoot pain in particular, and X-ray is helpful to try to exclude associated fractures, especially in the anterior process of the calcaneus, certainly because that does and potentially can change the management of these injuries. Sprain ligament tear, moving to the medial aspect of the hindfoot as well, the calcaneonavicular ligament in particular, and certainly important for stability and contour of the medial longitudinal arch, and is one of the static stabilizers of such. And this can, if disrupted, lead to an acquired flat foot deformity, an important point to remember. And it certainly can be associated with, or the result of, acute or chronic posterior tibialis tendon dysfunction or injury. And really looking for an asymmetric flat foot deformity in these cases, and screening for associated tib post dysfunction as well. Supportive footwear and orthotics may be helpful, and with higher grade tib post injuries or dysfunction, surgical reconstruction may be considered. Plantar fasciitis, certainly a very common presentation in sport and exercise medicine. We really should be terming this more appropriately a plantar fasciosis or fasciopathy based on the pathology. A number of predisposing factors that can lead to plantar fasciitis. And the typical presentation is detailed here. A number of treatment options here, from conservative therapies, injections, modalities, support, etc. Plantar fascia rupture certainly indicates an acute tear of this plantar fascia, and late complications include a symptomatic hypertrophic scar and a progressive pes planus. Predisposing plantar fasciitis is a risk factor, but certainly the mechanism of injury is an acute onset during a sustained stretch and or forefoot hyperextension. Often pop and acute pain are felt, difficulty weight bearing and push off, with associated swelling and possibly ecchymosis. And in conservative therapies, in a period of immobilization in an air cast with progressive weight bearing is tolerated over 3 to 4 weeks, and then further support with a rigid soled shoe with orthosis or a turf toe plate and progressive physio, and these individuals tend to have an average return to play of approximately 9 weeks. Fat pad contusion also can be an acute or chronic injury, and conservative therapies with foot modifications or support would be appropriate. Also, potential benefit to heel lock taping in this condition.